In this video, I'll be discussing the principles of surgery as it pertains to gastroesophageal cancer. I'm not a surgical oncologist, I'm a medical oncologist, but I'm hoping to be able to provide you with some basic understanding of these principles. Now, traditionally, removing the tumor where it started in the primary location in the stomach or the esophagus has been considered necessary in order to achieve long-term survival. And so we'll be focusing on that situation, but also discussing procedures that could be performed in the palliative setting and also alluding to oligometastatic disease that we'll reserve for a future video. But first, we have to review the normal anatomy of the esophagus and the stomach. So we see the far end of the esophagus here, called the distal esophagus, coming in to the GE junction, which is the junction where the esophagus meets the stomach, or gastroesophageal junction. And this leads into the top of the stomach, called the gastrocardia. The notch on the top is called the gastric fundus. Then there's the large body of the stomach, and then the far end or distal end of the stomach, called the antrum. And then the sphincter, which is a muscle that is called the pyloric sphincter, that really is the gatekeeper of gastric contents that to then flow into the first part of the small bowel, called the duodenum. And so this is a highly coordinated organ that has muscles that you can see here in the wall of the stomach and in the esophagus that are coordinated to contract and move food and liquids along, and again, through the pyloric sphincter in a controlled manner. In addition, we have to understand that the surgeon has to be aware of all of the blood vessel supply that is supplying the different regions of the stomach. And very importantly, the regional lymph nodes nearby the stomach and esophagus that are where the tissues drain into, and often, commonly, where the cancer first spreads to or disseminates to. In previous videos, we talked about the importance of staging and the staging imaging and procedure laparoscopy that helps to stratify patients into different stages, including localized stage, locally advanced stage, unresectable but localized, and spread distantly or metastatic. And for the most part, removing the primary tumor with curative intent is reserved for localized and locally advanced cancers. And we'll be focusing on that in this presentation. So with respect to curative intent, there are a number of different specialists involved, and we're going to first focus on an interventional gastroenterologist. An interventional gastroenterologist performs procedures including endoscopic mucosal resection and endoscopic submucosal dissection, as well as one of the staging procedures, endoscopic ultrasound. Their procedures are reserved for very, very localized early stage cancers. And in terms of their training, you can see here they've gone through extensive years of training through medical school and then residency in internal medicine, then a gastroenterology fellowship where a gastroenterologist, a general gastroenterologist, performs scopes like endoscopy, upper endoscopy, colonoscopy, and biopsies to get a diagnosis. But an interventional GI fellowship is required for them to then be able to do specialized procedures like EUS, EMR, ESD, and others. So as a refresher, when we talked about how we diagnose and stage the cancer, we talked about an endoscopic ultrasound, which helps us to get a local stage. It's better and more accurate than a CAT scan or a PET scan. So with respect to getting a local stage, the first part is the EUS helps with the T stage, or the tumor stage, which, remember, is how deep into the wall of the esophagus or stomach the cancer invades into. And so this ultrasound image is the endoscope in the middle of the esophagus through a cross section, and then these onion layers are the different layers of the esophagus. And looking here in this schematic, you can see this is inside the lumen, or inside the esophagus and stomach, and this is the most inner layer called the mucosa, epithelial layer, where the cancers originate. And then deeper down, there are different layers with different names like the muscularis mucosa, the submucosa, and others. These are the muscles that I was referring to that help to contract and move the food and fluids along. On the right, we see the different T stages that are possible at the time of presentation. On one extreme, you have a very superficial or in situ cancer that has not invaded very deep. You have a T1 lesion, which is invaded deeper, et cetera, down to T4. T4 can be differentiated into a T4A, a more superficial lesion, as opposed to a T4B, which is invading right through the wall and into adjacent organs. So that's the highest T stage, is a T4B. Something that should really be recognized is that the higher the T stage, the more likely that, or the more risk that there is spread to regional lymph nodes nearby. And so there's a percentage of cancers that are T1 that would spread to regional lymph nodes that are very small and non-detectable with scans or endoscopic ultrasound, less than 5%. On the other hand, at the other extreme, there's a really high chance that a T4 lesion will have spread also to regional lymph nodes. It's not absolute, not everyone has. There are such thing as a T4N0 or node negative cancer, but the majority of them will have to also spread to regional lymph nodes. So as the cancer gains the capability of spreading deeper into the wall of the stomach or the esophagus, it also has a higher chance to be able to get to regional lymph nodes and start growing there as well as to distant metastatic sites. In addition to getting a T stage from the endoscopic ultrasound, it also can help us get that end stage, the nodal stage. And this is an example of an image, again, the scope within the esophagus and all of the rings of the layers of the esophagus tissue, and then an abnormal lymph node nearby, a regional lymph node that looks abnormal. And so the endoscopic ultrasound can give us a clinical T and N stage. Over here, we see another important principle to understand is that lymph nodes are categorized by those that are very, very local, or N1, or also referred to when we're talking about surgical removal of them, D1. And then a little bit further away, deeper down, would be N2. And then very far away would be N3. And then finally, not shown on, would be really distant lymph nodes, like, for example, up in the neck or lower down in the belly. Those would be called M1 lymph nodes, or metastatic lymph nodes outside of a surgical field. When we get to the surgery discussion, we'll be talking about removing lymph nodes at least D1 and D2. Most agree that going deeper to do D3 resections is not recommended. So remember, from the staging, which we see here in the table, that you can see the different T stage based on the criteria of how deep the tumor has invaded. So that's the primary tumor. We see the end stage listed here, which is basically how many abnormal lymph nodes are involved. And over here, whether or not there is metastatic disease distantly, including, as I mentioned, lymph nodes outside of the regional setting. And then together, the T and M come together to make a final stage. And so you can see, as an example, a very early stage T1, N0, M0 would be a stage 1, as opposed to a T3, N0, M0 would be a stage 2B, as opposed to finally, if you have metastatic disease, any T or any N would lead you to be called the stage 4 cancer. So we're going to be focusing on what an interventional gastroenterologist would be doing with an endoscopic mucosal resection, and that is reserved for very superficial lesions that have not invaded very deep down, that there's no evidence of clinical lymph node involvement, and that there's no evidence of metastatic disease on CT scans and PET scans. And so we're talking about the most superficial tumors that can arise. Now, unfortunately, this situation is not that common. And as you see here on the left, the gastric cancer and on the right, esophageal cancer, the breakdown of where the stages are in terms of what patients are diagnosed with. And so you can see that less than 30% of patients have stage 1 gastric cancer when diagnosed. The majority of them are diagnosed at more advanced stages. Similarly, for esophageal cancer, less than 20% are diagnosed at an early setting of stage 1, whereas the majority are more advanced. And this is important because, as you can see here, the survival of the different cancers really depends on what the stage was at the time of diagnosis. And so when we talk about what therapies are used for each of these different categories of diagnosis, you can see here that the localized, whether it's localized or local regional, would be amenable to surgery, whereas if it's metastatic, it would traditionally not be recommended to undergo surgery. And therefore, they would be receiving palliative therapies like chemotherapy, targeted therapy, immunotherapy. On the other hand, locally advanced cancers with surgery alone have a very high recurrence rate, and that's because there is micrometastatic disease present at the time of diagnosis that we just don't see in a large proportion of those patients. So they go to surgery and then it recurs over the next months to years. And so, as we will talk about in the perioperative therapy videos, that it is standard to give adjunct therapy either before and or after surgery to enhance the cure rate. Despite that, there's still a relatively high recurrence rate. But in a proportion of patients, there can be long-term survival, and hence why surgery is an option here. And then, of course, in the localized setting, surgery alone is recommended because the outcomes are relatively good if it's found at that early stage. And the same is true in the esophageal cancer space. So again, going back to the interventional gastroenterologist, they are really focusing on really localized cancers that have not spread deep down into the wall of the esophagus or stomach, nor to the regional lymph nodes, nor to the metastatic sites. And so that's shown here, where you see that there's a very early cancer in the stomach in this figure, and an endoscopic view of that might not even show a mass. It may just show some other classic changes, but not an actual mass. And so if confirmed on biopsy and an endoscopic ultrasound reveals that it's not that deep invading, like a tumor in situ or a T1A lesion, then it would be amenable to local endoscopic mucosal resection. And so this is a figure showing what the interventional gastroenterologist would do. It's very similar to what a colon polyp would be doing in the colon side, where a polyp is there and through these different stages would be resected. So some important things to consider based on this that will actually spill over into the discussion when we get to the different surgeries is margins. What is a margin? A margin is the edge where the cuts are made to ensure that we've removed all of the cancer. And so a circumferential margin is on either end of the actual mass that's being removed. This is the circumferential margin. And so down below, we see different scenario outcomes of what could occur. We can see a negative margin, which is what is desired, also referred to as an R0 resection, complete resection. And so what you see here is that the cancer, there's space between the edge of the cancer and the edge of the cut, which is a good thing. On the other hand, these two examples over here are positive margins. This first example is a positive margin in one location, and this other example is a positive margin in two locations. And so the reason why this could occur is that visually, it looks like the endoscopist is getting all of the cancer out, but microscopically, even though it looked normal in the area that they cut, there were cancer cells going right up to where they cut. And the concern of a positive microscopic margin, or R1 resection, is that there could be residual cancer cells right on the other side of the cut that is left inside the body. And so hence why that would be a very high risk of a recurrence in the future as it starts to grow back and to become a problem. So in addition to the circumferential margin, in this case of an EMR, endoscopic mucosal resection, is that we want the deep margin, the bottom part of where they've cut out the cancer to also be negative at the margin, because of course we don't want residual cancer cells left here either. And so the idea of doing an EMR is that it's been identified as a very superficial mass, and so that we can scrape it off essentially and remove it. And because, as I mentioned in the previous slide, the risk of having microscopic spread to regional lymph nodes when the cancer is so superficial is exceedingly low. And so it has been shown that this is sufficient to remove and eradicate the cancer without doing a more aggressive radical surgery, removing the whole stomach and regional lymph nodes. What if the cancer is a little bit deeper down? And so instead of a T1A, it's a T1B. So now it's a little bit deeper down into that submucosal layer. Traditionally, this would be an indication for surgery to remove the stomach or esophagus and regional lymph nodes, because there is a risk that there could be a spread to regional lymph nodes that are microscopic, that aren't detectable on endoscopic ultrasound or PET scan or CAT scan. However, with a recent procedure description called an endoscopic submucosal dissection, essentially is the same thing, but it's doing it to a deeper level, cutting it to a deeper level. And again, this is reserved for relatively superficial T1B lesions, and that have a relatively low risk still of metastatic spread to regional lymph nodes. Okay, so that is the very superficial lesions. What about the majority of patients, though, that don't have that really superficial lesion, but have still a localized or locally advanced cancer? Well, wherever there is an S on these figures, surgery is recommended to be performed. In fact, it is the main therapy to be used. The other adjuncts like chemotherapy and chemoradiation are adjuncts to enhance the benefit of the surgery. And the reason why I point this out is because a lot of patients ask, is there a way to avoid the surgery in this setting and just get chemotherapy or chemoradiation? And I liken it to going out for dinner and having your appetizer and your dessert, but not the actual main course. And so the main course, the surgery, is really what is the main component of the therapy here to remove this cancer. There are some examples of where definitive chemoradiotherapy can be used, DCRT, predominantly in esophageal squamous cell tumors at this point. So again, for surgery, we're talking about these localized stages. And we previously discussed the training of a surgeon, and a surgical oncologist is specifically trained for the treatment of cancers and in the art of resection of the primary tumor of where the cancer originated, generally with curative intent. However, I will allude to a situation called oligometastatic disease at the end of the talk, and set that up for a future video that is dedicated to that, as well as occasionally palliative surgeries in the setting of stage 4 disease, but still surgery is performed. So again, when we're talking about the stages here, we're talking about more advanced T stages, more advanced nodal stages, and at the same time, not metastatic classically. And so again, on the table, that's referring to stage 1 to stage 3 cancers. Again, the higher the stage of T and or N, and the final stage, the higher the risk that there is microscopic metastatic disease at the time of diagnosis, at the time of going to surgery. It's just that we don't know it's there. And some patients have that and some patients don't. And so without any further information, we do surgery in these patients because a proportion of them can be cured, despite knowing that a proportion will also recur. So here on this figure, we're talking about this localized and local regional or locally advanced form of cancer in the stomach and the esophagus. One final point, and we talked about at length in the how do we diagnose and stage cancer, is in the setting of a cancer that is staged clinically as being T3 or higher, which is a very common T stage for both esophagus and gastric cancer, and or any T-stage but node positive disease on imaging and endoscopic ultrasound. These patients have a high risk of occult spread to the peritoneal cavity, which notoriously on CAT scans and PET scans and endoscopic ultrasound goes under the radar and can be present, but we just don't see it there. And so it is the highest risk in patients that have diffuse type gastric cancer, where approximately a third of these patients, despite having completely negative CT scans, PET scans, and other exams, suggesting no evidence of metastatic disease anywhere, will have spread to the peritoneal cavity. The risk of spreading to the cavity is higher or highest in the stomach, more so than the G junction, and the least in the esophagus. And so really diagnostic laparoscopy with washings, spraying fluid into the abdominal cavity and collecting it and then looking at it under the microscope is recommended for the stomach and G junction cancers that fit into a clinical T3 and or node positive disease. And it's recommended to at least consider it for the far end of the esophagus adenocarcinomas. And again, if it is present, if there is disease present there or cells present in the cytology washings, then the staging would be upstaged to an M1 cancer or stage 4. So assuming that there is no definitive evidence of metastatic disease on all of our staging imaging and laparoscopy, then the next thing to understand is that the primary tumor location where the cancer started really helps to determine what type of surgery the surgeon is going to perform. In addition to the location of the tumor, the size, the extent of the tumor, how much of that area it's encompassing will play a role into what the surgeon ultimately is going to perform. And also the histological pattern. We talked about diffuse type versus intestinal type, signet ring cells, which track with diffuse type cancers, will also dictate what type of surgery is going to be performed. Remember, diffuse type, which is shown here on the far right, often and usually affects the whole stomach. And so we're talking here about a total gastrectomy that needs to be performed, which is shown here on this image. On the other hand, the location within the stomach, if it's at the proximal end of the stomach, the top part of the stomach, versus the far end or the distal end of the stomach, this will dictate which types of gastrectomies would be performed. So first to start, let's take into the scenario of an antral cancer, a cancer at the far end of the stomach, where the top part of the stomach is not involved. It's not a diffuse type gastric cancer, it's an intestinal type. And so what's shown here is a classic surgery, a low subtotal gastrectomy. Low meaning the cut is low in the stomach as opposed to high, as I'll show you in a minute. And one form of this is a procedure called the Billroth 2 gastrojejunectomy, where you can see that after the stomach is removed, is that part of the small bowel is brought up and connected to the stomach. This connection is called an anastomosis. And so when we get to complications of surgery, one of the concerning complications of any such surgery is leakage of this anastomosis. Now, we talked about pathology and processing of samples in the biomarker assessment of tumors and showed that the pathologist, when they get the specimen, will process these in formalin-fixed and paraffin-embedded blocks, or FFPE, and there will be a number of blocks from a given surgical specimen, including the actual tumor itself, but also, very critically, the margins, the proximal margin, the top part, and the distal margin, the far part. And remember, this is an important assessment to assess whether the margins are negative, are R0 resection, complete resection, versus microscopically positive, versus the worst would be, of course, the surgeon knows they're visibly leaving tumor behind, but they were unable to remove it for some reason. So these are to be avoided at all costs and are not performed that routinely. And so regardless, this would be called an R2 resection. More commonly, they're going to be an R0 resection or an R1 resection. And as noted, these would be referred to as the distal and proximal margins. And remember, the importance of this is that if it's present in the surgical specimen that was removed on this side, then it's highly likely that it would be left on the other side of the distal margin, for example, or the proximal margin in the anastomosis. And we would like to avoid that at all costs for obvious reasons. So in addition to removing the primary tumor, the surgeon will remove regional lymph nodes systematically. And in the brown here are those lymph nodes in the nearest vicinity referred to as D1 lymph nodes. So a D1 lymphadenectomy would only remove these very close lymph nodes. Deeper down again are the D2 lymph nodes. And so it has been shown repeatedly that a D2 lymphadenectomy is optimal to achieve long-term survival. And so removing lymph nodes or harvesting lymph nodes is important, first, because it will optimize the staging. So if you don't remove these lymph nodes and there was actually cancer there, then you would be likely understaging the patient by only removing the other nodes. And also a treatment, because you're removing the areas of cancer. And so we'll get to this as we get to the proficiency of the surgeries being performed, and that surgeons who do these procedures more are more proficient at getting these lymph nodes removed. And remember, all of these blocks would be available for the pathologist to review on clinical slides, and these could be reviewed as a second opinion of pathologists to weigh in on the stage and the margins in a second opinion. So I showed you a Billroth 2 procedure that was a low subtotal gastrectomy. This is an example of a higher subtotal gastrectomy or a near total gastrectomy. And the surgical procedure called a Roux-en-Y gastrojejunectomy. So you can see there's sort of a Y figure that's created by the surgeon. And so again, the decision on which surgery is going to be performed, the surgeon takes into account the tumor location, the size, the histological features, and their concern is to ensure that they are getting a negative margin. That is primary concern of the surgery, is to ensure that you're getting it all out. Again, with this same surgery, they're going to be doing a D2 lymphadenectomy optimally. On the other hand, if there is a tumor that is in the body or in the cardia, but a large tumor, or certainly if it's diffuse type, then for the most part, surgeons are performing total gastrectomies where the full stomach is removed, and a Roux-en-Y esophageal jejunostomy is performed. So the esophagus is connected to the part of the small bowel, and the remnant stump is left here. And you can see that the pancreas and the bile duct still drain into the duodenum. And so this will become important when we get to complications after the surgery and symptoms that one can have based on a number of different complications that could occur. And again, with any surgery, lymphadenectomy, removing the lymph nodes nearby, a D2 lymphadenectomy is performed. On the other hand, if you have a tumor in the cardia or in the high fundus or the high body, and localized, not diffuse type, then a surgeon may opt to perform a proximal subtotal gastrectomy. So instead of taking the far end, it's taking the top end where the cancer is and sparing the far end and keeping that in place. And so the final result is you still have a functioning pylorus sphincter, which is very critical. We'll get to that as well when we talk about dumping syndrome and what types of procedures have a higher risk of getting dumping syndrome. You can imagine, though, that in the cancers where you're removing the pylorus sphincter and not having a lot of reserve as a stomach, you'll have a higher risk of getting a dumping syndrome. Again, D2 lymphadenectomy is performed. Another common question that we talk about is a classic open surgery where the incisions on the abdominal cavity are long, or called a laparotomy, versus the more contemporary types of surgeries, including laparoscopic gastrectomies, where very small incisions are used and the surgeon is using a scope inside the belly cavity to do the surgery. And so it was anticipated that laparoscopic gastrectomies would be better tolerated and lead to less post-operative recovery time in the hospital. And so studies have looked at this, and in this particular study that I'm showing here, recently published, was a randomized study called the Logica study, and it randomized a number of patients to getting either a laparoscopic surgery or an open gastrectomy. And the primary endpoint was time after the surgery in the hospital. And the thought or the hypothesis was that the laparoscopic surgeries would have a shorter recovery time. However, it was observed that the median hospital stay was about a week in both groups, so it wasn't that much different. As might be expected, though, the median amount of blood loss during the surgery, there's always a little bit of blood loss during the surgery, was lower in the laparoscopic group. However, the time during the surgery was a little bit longer, and that's because it's harder to manipulate through the little incisions as opposed to having an open and being able to just go right at what they're trying to do. On the other hand, some other important endpoints that were looked at weren't very different for a full year post-operatively. And so, for example, post-operative complications were similar. In hospital mortality was not statistically different. 30-day readmission rates were the same. R0 resection rates, which of course is a paramount thing to look for, were the same. So the oncologic surgery was similar. The amount of lymph nodes removed, which again I mentioned was very important, were similar. And the survival shown over here was pretty much identical. And so there was no real difference either in quality of life, and so based on questionnaires. And so overall, the conclusion here is that these are both options. There's not one that's otherwise better than the other, and that ultimately it's really the surgeon and their comfort level with respect to which procedure they're performing. Rather, what is actually more important is the surgeon's expertise, their volume in terms of how many surgeons they perform annually of the stomach resection. And so this has been shown over and over again, but a recent one looked at the Kaiser Permanente group in Northern California. And what they did was, back in 2015, 2016, they did something called regionalization, which was prior to regionalization or pre-regionalization, patients with gastric cancer were undergoing resection from surgeons at multiple different centers throughout their network, even if the surgeons were performing very, very few surgeries annually. After regionalization, what they did there was they created centers of excellence within their system. And so that surgeons were became high volume surgeons, and that they became more specialized in these procedures. And so they wanted to look at what were the outcomes in patients that were having surgery with surgeons that were not performing surgeries frequently compared to the more specialized, centralized performance of surgeries. And they looked at, of the total cohort of patients evaluated, a proportion of them, almost 400, were receiving curative intent gastrectomies. And what they first noticed was that the utility of neoadjuvant chemotherapy, which is a standard of care and preferred, increased in the patients pre at 35% to post about 2/3 of patients. So the reason why this is important is because it's really the preferred way. And when we get to the curative intent videos, you'll see that there's a couple of different options. You could go directly to surgery and then have the chemotherapy after surgery, but it's preferred to do some before because it helps with getting R0 resection rates by shrinking the tumor and allowing the surgeon to get negative margins. And so this is an example of, by doing things in a high volume center, you get more of the preferred therapy approaches. This is the most important one, in my opinion, in that the D2 resection was increased from 2% to 80%. So this is really important because we know that that affects survival. The length of hospitalization also decreased after surgery. So again, with a proficient surgeon and their team who's doing this more routinely, we get better outcomes across the board. That said, there was no real differences in complication rates. The surgeons are still surgeons and they're adept at what they're doing. That said, because of these things, particularly because of the neoadjuvant chemotherapy utilization, the D2 lymphadenectomy increase, and also better staging. So patients that were having stage 4 disease that was not recognized weren't getting gastrectomies that probably were spared from a surgery that wasn't helping them. The survival of 2 years was improved. And so this is not any novel therapy. This is not immunotherapy that's improving survival. This is just getting surgery from a surgeon who is highly experienced at a high volume center. This is one of many studies that have shown that. What about tumors that are at the G junction of the esophagus? So this is an example of a GE junction cancer that often straddles the far end of the esophagus, the distal esophagus, and into the top of the stomach. It's not uncommon to have a cancer that goes high up into the esophagus and down farther into the stomach through the whole cardia. And so again, these types of cancers are becoming more predominant in our clinics in North America. In fact, it probably makes up 2/3 of the patients that we see compared to, say, stomach cancer or esophageal squamous cell cancer. And so what type of surgery is performed here? This would be called an esophageal gastrectomy, where you would have the top of the stomach removed up to the esophagus and this part removed, and then the remaining stomach or the stomach remnant pulled up into the chest and then created an anastomosis of the two remaining ends. This picture is showing a mid-esophageal cancer that is getting removed and having an esophageal gastrectomy, but this would also be performed for a G junction or a cardia tumor that's invading up into the G junction and esophagus. Again, regional lymph nodes would be removed with such a surgery, and this would be referred to as a two-field lymph node resection. So again, adequate node removal is helping to adequately stage patients, but also is treating, because it would be removing cancer that had spread to regional lymph nodes. In some patients who have a high cancer in the esophagus and no involvement of the G junction, an esophagectomy without removing the top part of the stomach would be performed, where the incision would be a little bit higher. And again, though, the stomach remnant would be pulled up into the chest and connected through an anastomosis. Again, in this surgery, a two-field lymphadenectomy would be recommended. Now, to do an esophagectomy or esophageal gastrectomy, there have been different surgical approaches. And so you may come across this when you're getting a consult, because different surgeons address this problem or tackle it a little bit differently. And that's because there are different approaches that are accepted. The first approach, which was detailed more than 100 years ago, is called a transhiatal esophagectomy. So what that involves is a laparotomy incision in the abdominal wall so that the stomach can be mobilized and that the far end can be cut, and then a cut up in the neck where the surgeon can then work from the other end and make a cut at that end, at the top end of the esophagus. And then the surgeon from below would be going in blindly because the thoracic cavity has not been entered surgically. And so with this blunt dissection would be removing the esophagus and the top part of the stomach, if it's an esophageal gastrectomy, out of the larger incision from below. And then the remnant stomach is pulled up through the chest wall and reconnected. And it's reconnected, or that anastomosis is performed up in the neck area. And this becomes important because with that cervical anastomosis, if there is a leak, it is in an area that is easily managed and can be addressed relatively minimally invasively. It's not inside the chest cavity. And so again, the advantages of this procedure are that there's no thoracic incision. And so pulmonary issues after the surgery with breathing, because if you have an incision in your chest, it may be difficult for you to take deep breaths. And so you're at higher risk for pulmonary infections. Because there's no thoracic incision, recovery times are thought to be a little bit better. But at the same time, it's a blunt and blind dissection from below. And so the concern is that maybe we're not adequately getting all of the regional lymph nodes out. So there's a trade-off potentially there. That said, for the cancers that are at the far end of the esophagus and at the G junction, where the cancer resides, this is more than amenable to this particular procedure. On the other hand, an esophageal cancer that's high up in the chest would be more challenging from a transhiatal approach. So what is another approach that I've sort of been alluding to, and that is the first one being called an Ivor-Lewis approach. And so this is usually performed by a cardiothoracic surgeon, as opposed to the transhiatal is usually performed by a general surgeon that's trained in oncology. And this Ivor-Lewis procedure, you can see here, has a different approach. It does have a laparotomy from below, and all of this, the procedure that would have been performed from a transhiatal, is identical. But instead of a cervical incision, they do an incision on the right side of the thorax. And so the advantages potentially of this are that you can better visualize the actual esophagus and regional lymph nodes and get a better lymph node removal. But at the same time, the trade-off is that now you have a thoracic incision, and so post-operative recovery may be a bit more challenging. And importantly, the anastomosis is inside the thoracic cavity. And so if there's a leak, this could be catastrophic. And so you'll see on the later slides that the rates of intrathoracic anastomosis with such a procedure like an Ivor-Lewis are relatively low, but they can be very serious. On the other hand, with a transhiatal anastomosis up in the neck, even though it's not as serious, it tends to happen a little bit more frequently. So these are the discussion points about the differences comparing between transhiatal and transthoracic. Finally, just to round it out, there was another procedure described by Dr. McCown, who did 3 incisions, basically sort of a merging of the Ivor-Lewis and the transhiatal approach. And again, the advantage here would be that you can do the anastomosis up in the neck and spare from the negative consequences of an intrathoracic anastomotic leak. But now you have 3 incisions. And so there also is a trade-off. And so again, different surgeons have different comfort levels with each of these procedures, and in certain circumstances may prefer one versus the other. In addition to the differences in those approaches, there's also differences in the usage of novel technology like laparoscope and thoracoscope and robotic surgeries. And so compared to conventional surgeries, which, as you can see here on the left here, have larger incisions like a laparotomy or a thoracotomy, the thoracoscope and the laparoscope incisions are smaller. And so I showed you when we talked about it in the gastric cancer space that studies are comparing these different strategies and ultimately are showing that they don't negatively affect the outcome, that they're safe to do in the hands of an experienced user, but they're not necessarily better per se. And that's shown here, where a number of studies have looked at comparing in randomized studies the outcomes of patients who underwent a transthoracic versus a transhiatal approach. And you can see that overall, they're considered equivalent in most of the important outcomes. I mentioned, though, that transhiatal may have a higher rate of anastomotic leak, and you can see that here, that the rates are slightly higher compared to transthoracic, but they're not as serious and when they do happen, because they're right in the neck and easily accessible and can be managed pretty non-invasively. On the other hand, we mentioned that transthoracic may have higher pulmonary complications, as you can see here in these studies, because you're entering the thoracic cavity, and so recovering after that can be more challenging. But again, overall, it's really a matter of surgeon comfort and experience in terms of what they prefer to do. Much more important, similar to what we showed in the gastric cancer setting, is that those surgeons that do the surgery, whatever it is that they're doing, frequently and often are the ones that have better outcomes. And we've known this for some time, but recent studies even have shown that this is the case for esophageal cancer. And this one study shown here was a study that was looked at in Sweden with 139 surgeons, almost 2,000 patients that had esophagectomies between 1987 and 2010. And what they showed was that the surgeons who were performing higher numbers of surgeries had lower 30-day mortality. So this is referred to as like post-operative mortality within a month of surgery. And even 90-day mortality is lowest among the surgeons who are doing a lot of surgeries. Procedure number means how many surgeries they've been doing. And so you can see that, on the other hand, those who are performing very few surgeries are having higher mortality rates. Similarly, the more surgeries being performed, the more likely you're getting higher numbers of lymph nodes, which again, I've been showing you is a very important factor. Similarly, those that have positive margins, R1 resection or R2 would be residual disease that the surgeon knew they were leaving behind, are highest among those that are doing fewer surgeries. And finally, having to undergo a reoperation for whatever reason is also lowest in those surgeons who have been doing this a lot. So the sum here is that you want to get your surgery done by a center that has high volume, that is doing this frequently, that has a team around the surgeon that understands the post-operative management very well and can get you through this as best as possible. So I'm going to talk now about some of the complications that occur after a gastrectomy and esophagectomy. So first, with a gastrectomy, things that we're looking at and considering are how long after surgery. I showed you a study that looks at that as an endpoint, because the longer you're there, that means there's complications. Infections are a complication post-operatively in the wound, also in the lung with breathing, particularly after transthoracic opening of the thoracic cavity. Deconditioning while you're there and trying to recover, pain in the wound and healing of the wound can all be complications if they get infected, for example. In addition to that, feeding after surgery is a really important thing to consider. You've just had your esophagus or stomach removed, and you're trying to get used to this new anatomy. And most probably, a surgeon is going to leave in place a jejunostomy tube, which is a feeding tube that goes directly into your small bowel to feed while you're recuperating and recovering here in the surgery that was performed. And then over time, they will give you sort of a schedule of how to advance your diet from liquid diet to your softer diet, et cetera, to more solids, et cetera, until you get to a setting where it is felt that you can sustain yourself normally, and then the jejunostomy tube is removed, usually several weeks, if not months, after the surgery. Some patients leave it in place to supplement their nutrition for a long time after, just because of the difficulties with eating that we're going to go through. One of which is, now you've had part or all of your stomach removed or your esophagus removed. And so a common problem in gastrectomy is that you feel full quickly. You can't eat as much at a given time. And so these are all sort of lifestyle alterations that you need to get used to. In addition to that, there are a number of complications that could occur acutely or over the next weeks and months. And I'll talk about some of them just to point out that these are things to be aware of. They include the acute complications like an anastomotic leak, which I mentioned, which can lead to infection and other problems, and sometimes need to be revised with a repeat surgery and to try and correct that leaking. I had shown images of the surgeries that were being performed, and that there is that duodenal remnant stump that's there where the pancreas and bile duct still normally function and treat the bile and the pancreatic enzymes into to help with digestion. But there's that blind pouch that's sitting there that could blow out, and it's a leakage from that area that can be serious with infection and sepsis. And so this is an emergency complication. Thankfully, this is not common, but it is something to be aware of. There are a number of other complications that you see here. We'll go through dumping syndrome and metabolic alterations, as well as stasis and diarrhea. There are a number of other complications that can occur as a consequence of the new plumbing that's gone on in the abdominal cavity. And then there are longer term complications with ulcerations in the stomach. And something that you should be aware of is that there's a known phenomenon of cancer that occurs at the anastomosis of where the connection was made. And so, with respect to a lot of these complications, particularly like dumping syndrome and some of these others, the type of surgery can actually differ in these symptoms and differ in the degree of the symptoms. For example, total gastrectomies are typically the ones that are most difficult to get through because of some of these complications. So let's look at some of the common things that a patient might experience after a gastrectomy. We'll talk about dumping syndrome and a bunch of other metabolic alterations. Dumping syndrome is really, there's two types of it. The first one is where you're eating, and within 30 minutes, you're getting diarrhea, abdominal pain, cramps, excessive gas, fast heart rate, dizziness. You get dizzy when you stand up, or something called postural hypotension. And the thought is that this is because of when you're eating, if you have a lot at one time, the osmotic shift of volume in your blood vessels goes into the stomach remnant. And that's because normally, as we pointed out at the very beginning with the normal anatomy, food and liquids are being pushed along at a controlled manner. And so when part of the stomach is removed and you get this faster movement of liquids and food, then you're at risk of causing this type of issue. And then there's a second type, which is usually occurring at a little bit later after eating, 1, 2, 3 hours later. And the thought here is that, again, because you're getting this bolus of food that's usually being released slowly in through your gut, it's going through quickly. And so you get this excessive uptake of sugar from the food into the bloodstream. And that leads to a reflexive huge increase in insulin to drop the blood sugar. But then you bottom out and you get low blood sugar because of this huge amount of insulin. And this low blood sugar, which we call hypoglycemia, can lead to diaphoresis, tachycardia is fast heart rate, tachypnea is fast breathing rate, and just not feeling well. And so there are certain surgeries, and that, as I mentioned, there are certain surgeries that be at higher risk of these. A Billroth 2 is thought to be a higher risk of getting these. And again, you're seeing that you're dumping into the small bowel faster than you normally would have been. And so it leads to some of these complications. However, there is a lower incidence of at least this early dumping symptoms in older patients, it's noted, and in patients who are getting a Roux-en-Y rather than the Billroth procedures, and certainly in pylorus preserving procedures that are showing like a proximal gastrectomy, which leaves the far end of the stomach in place. And so the sphincter is still functioning, and so it's able to control how much of the stomach contents are going out at a certain rate. And so you're limited in terms of this dumping symptoms. How do we manage dumping syndrome if the patient does have these symptoms? Well, there are some dietary measures that are often sufficient to deal with most patients. Eating slowly, frequent meals that are small as opposed to what we're used to, large but infrequent amounts of meals. Eating upright is noted to alleviate some of the symptoms. Avoiding high sugar foods like ice creams, colas, etc., particularly for that second type of dumping where you get this huge insulin burst and then hypoglycemia after, limiting the fluid consumption prior to meals so that by at least a half hour, and higher protein diets, high fiber diets can help to slow things down. And if this has been documented that the reason why you're feeling this after eating is because you do get low blood sugars, and despite all of these other maneuvers, of course you want to have some measures available for emergency, like orange juice nearby to rescue your blood sugar and bring it back up to alleviate the symptoms. Diarrhea can be caused from a number of different things, including these issues. Also, though, due to bile acid malabsorption, again, because of the replumbing that's gone on there, some drugs like cholestyramine have been used to try and alleviate that with some success. However, if all of this stuff that you're trying to do is not helping, then there are a number of other things that one can try in the refractory setting. It's not working with the first sort of pass of things to try. That can be using drugs like Imodium, anti-diarrhea drugs like Imodium or Lomotil, using a drug called octreotide or octreotide long-acting release, which is a shot under the skin or subcutaneous that is useful in some patients. Other things like pectin and guargum and glucomannan that can help to slow the gastric emptying that's clearly happening too quickly. Moving on from dumping syndrome, there are other things like metabolic syndrome. So a classic thing is that you can get and develop iron deficiency anemia. Again, this is one of the things that can lead to the original diagnosis of stomach cancer because of blood loss that's occurring from the cancer. But now what we're talking about is after your surgery, factors are changed. And so your stomach is not as acidic, especially if it's the far end of the stomach that's been removed, the antrum and pylorus. And so iron needs acid to help be absorbed in the first part of the small bowel called the duodenum. And so because you've had replumbing go on there and you're less acidic, you may have low iron absorption. And so after ruling out the possibility of bleeding from other sources or any other obvious reason for having anemia, then iron replacement is recommended, often IV, to help boost up your red blood cell count. Similarly, after a resection of your stomach, you can't absorb a B12 as well. So patients should be checked for B12 levels and administered replacement of B12 by an injection every 3 months. Similarly, along the lines of malabsorption, calcium is a problem, and therefore getting low calcium in the bones or osteopenia. And so replacement orally with calcium and vitamin D is recommended. And many other nutrients can be low because of malabsorption after replumbing and bypassing around the first part of the duodenum where a lot of absorption occurs. And so, these things need to be taken into account and also can be contributing to weight loss. There's something called bacterial overgrowth. So again, because of the replumbing and the areas in the duodenum that are not moving like they normally would, you can get bacterial overgrowth that then can worsen malabsorption and also diarrhea. So moving on then from those metabolic issues, you can also get something called gastric stasis. So the opposite of too fast going through, this is that it's not coming out fast enough, or something that's called delayed gastric emptying or gastroparesis. And the thought here is because one of our major nerves that comes and innervates the stomach area, called the vagus nerve, it's what is synchronizing our stomach and gut motility. And so when the surgeon comes in to remove the stomach, this inevitably can be denervated, cut, and that can lead to delayed gastric emptying, gastroparesis. So symptoms from that can be you're getting full quickly, you're having a lot of regurgitation, nausea, vomiting. You can get an endoscopy to evaluate what's going on, and you haven't eaten anything for 48 hours and there's still food residual in the stomach that the endoscopist notes. And so this would be an example of gastric stasis problem, and gastroparesis. Things that could be tried to help with that are medications, oral medications like metoclopramide, also known as Reglan, and others, erythromycin's an antibiotic, but it is a gut motility stimulator. And so this can help to move things along and move it forward. If it's refractory to these types of measures, there are some other procedures that could be performed, but we try to avoid these, like, for example, a reoperation to a total gastrectomy to see if that can help. Similar to post-gastrectomy complications, post-esophagectomy have a lot of similar things to consider: hospital stay after the surgery, infections and risk for that, deconditioning, pain at the site of the incisions, and healing of those incisions. They could become infected. And then very much so worry about feeding. And so patients tend to have jejunostomy tubes placed as an insurance policy to help get them through the weeks and months after surgery until they're able to eat on their own. Again, similar to stomach gastrectomies, feeling full very quickly is a common problem. But one of the things that I know from my patients telling me is that after an esophagectomy, they don't know when they're full. They keep eating, and then all of a sudden it's like feeling like it's up in my neck, and you feel miserable after that. And so it's a learning process on what is the new norm and how to eat small frequent meals, and know that you're going to get full even though you don't feel it per se. And so these are things that you learn post-operatively. In addition to that, because the GE junction, which is similar to the pyloric valve, it's not a true valve, there's not an actual muscle there, but it acts like that and prevents reflux of contents from the stomach and the bile duct into the esophagus. But now that this has been removed in your new situation, you have free flowing fluids and food that you've eaten when you lie back. And so you will be recommended not to eat right before bedtime, for hours before bedtime, and to try and sleep a little bit at an incline for letting gravity pull things down as opposed to laying back and letting everything fall back. Patients here can still experience dumping syndrome, excessive gas, cramps, abdominal pain, bloating after eating, nausea, vomiting. Also, I have some sort of malabsorption, weight loss because of all of these things going on. You can also later on get dysphagia. Remember, that's problems with swallowing, things getting stuck. This can be from stricturing of the area after surgery. And it would be a benign stricture. It wouldn't be from cancer per se, although we would want to rule that out with an endoscopy and evaluation of that. But if it's ruled out as a cancer recurrence, it could be just stricturing that's there after the surgery. It certainly can be a little bit higher risk of getting this if you had radiation beforehand compared to no radiation before. And so for a lot of these things, it's really challenging to get through the post-operative weeks and months right after esophagectomy. But for most patients, it gradually improves over time. It can take months and even years before like they're really feeling better. Part of that is because you're learning about what works and what doesn't work. But some things, despite all that, still remain there, and you know it's there, you know that you have to deal with it, and you come up with strategies on how to address each of these, and it becomes really a new norm. So we talked about the different surgical approaches for gastrectomy, esophagectomy, the location of the tumor, the size and extent of the tumor, the histology of the tumor, the surgeon's expertise and comfort will all determine which procedure out of many choices in some cases would be performed. There are some standard things to do, like D2 lymphadenectomy for stomach cancer, 2-field lymphadenectomy for esophageal cancer. And also, we talked about the expertise to help stage patients accurately. The laparoscopy, very important. because if there's metastatic disease, but you're getting these aggressive surgeries, at least at the first presentation, is really not the right thing to do. But in addition to better staging, then higher volume centers, higher expertise can better treat patients. And we've seen that now with pathologists when we're doing biomarker testing and staging. And now we're seeing that with surgeons in terms of the proficiency of their surgeries and outcomes. So now I'm going to focus my attention to palliative setting, or the classic setting that would not be amenable to surgery, historically speaking. And for the first, I'll start by saying the reason why I've gone into some of the post-operative complications and new lifestyle sort of adjustments is because we wouldn't want to do that in the setting where we know we're leaving cancer behind. Because yes, if there's a curative potential, then most patients, when asked about this, would be willing to undergo these procedures and deal with the consequences later, if it means that there could be long-term survival. On the other hand, if we're talking about cancer that has spread already, it's stage 4, doing a primary surgery of the stomach, and certainly for the esophagus, which is even more difficult to get through, along the lines of a total gastrectomy, then it's really not in the best interest in terms of quality of life, which is really the name of the game in the palliative setting. And we'll get to that when we get to treatment videos, curative versus palliative settings. That said, there are some situations where interventions would be considered, even in the outright setting of stage 4 disease. So a very common one is obstruction from the primary tumor of the pylorus valve. And so this is a cancer that started in the pylorus, and it's gotten large enough that it's blocking exit of all of the stomach contents above it. And so even in the setting then of metastases to the liver or the peritoneal cavity or the lung or the bone or combinations thereof, we would consider palliating this problem. First, always, it would be preferred to try systemic therapy if you can get it started quickly enough. And so systemic therapy would affect the metastatic sites, but also this primary tumor site. And if it was to shrink it down, then it would open this up again, and we wouldn't have had to do any interventions or invasive procedures. That said, sometimes patients are pretty advanced with their obstruction here, gastric outlet obstruction. And so it needs to be addressed before we can even get any therapy started. And so one preferred way to deal with this would be from an interventional gastroenterologist who comes in, does an endoscopy, and places a stent across the obstruction, a stent that props that area open and allows things to flow through. And so this usually works pretty well. And that said, over time, this cancer could start to worsen to the point where it starts to get what we call stent ingrowth or overgrowth. And so the cancer grows around it and blocks it over time. In addition to that, stents can get clogged with food and things that are coming through. And so sometimes need to be revised, and endoscopist has to come through and clean it out. Sometimes another stent has to be placed inside this stent if there is cancer ingrowth into the stent. So that said, we're talking about a setting where we have metastatic disease that can also be symptomatic, and we're trying to temporize this problem as quickly as possible so that patients can eat and maintain their energy levels to withstand therapy. And so a quick procedure like this is often the best strategy. That said, in some cases, an endoscopist can't get a stent through this area because it's too tight, it's too narrow. And so in that case, some things could be considered. A palliative surgery, particularly because it's just at far end of the stomach, it's a subtotal gastrectomy, and so could be performed. However, with respect to doing an intensive lymphadenectomy of D2 resection, probably would not be performed because we know there's metastatic disease in the liver, et cetera. And so going and getting an extensive lymphadenectomy is not warranted, but rather we're just doing this to try and do this quickly to remove the area that's obstructed. More preferred would be something that is called a gastric bypass, where the cancer is actually left in place, but there is a bypass around that area. And the advantage of this is that this surgical procedure takes less time. So you're in the operating room less. The recovery time is therefore less. And so we can get you back on your feet and eating relatively very quickly, feeling well, and able to get systemic therapy to palliate all of the cancer, not only this primary tumor, but everywhere else that it may be. As opposed to more intensive surgery requires recovery time. And so while you're recovering, we can't be giving chemo, for example. And so all of that other metastatic disease is growing unchecked, right? So again, quicker procedures are preferred here so that we can get on with therapy that can control everything else. It's a very common question, and it's understandable why patients ask, can we have my primary tumor removed? I just don't want it there. And so in the setting of stage 4 cancer. And so along the lines to the arguments I was just mentioning, that surgery can delay the introduction of actual systemic therapy that we know is helpful, not only for the primary tumor, but for all the other metastatic sites. And so this was a study called the Regatta study that was reported in 2016. And this study was for patients that had gastric cancer with peritoneal disease only, so a subset of stomach cancers. And the study was looking at whether resection or surgery removal of the primary tumor led to better outcomes compared to those who had the primary tumor left in place. And at the same time, all the patients had their peritoneal metastases left alone. There was no removal of those peritoneal disease. There was no chemo given by HIPEC. And in the study, you can see on the bottom curves, there was no difference in the rate of growth of the cancer, progression-free survival. And there was a slight disadvantage, actually, in red, you can see, for patients who had a gastrectomy and chemo compared to those who just got standard chemotherapy in the newly diagnosed stage 4 setting. And the thought here is that these patients are undergoing recovery from their gastrectomy, and they're not able to get the actual therapy, which is controlling the metastatic disease. And so other than those examples I showed you where a surgery is really required because to palliate and to be able to eat, it's required to bypass around the primary tumor, for example, if a stent isn't possible, maybe then. But overall, though, doing surgery on the primary tumor, it doesn't lead to better outcomes. And we've been talking again about complications after such surgeries like a total gastrectomy, is really not going to improve your quality of life. In fact, it may make it much worse. Moving up to the esophagus, where I mentioned that on occasion we'll talk about a palliative surgery in the stomach. Really, there's no such thing as a palliative esophagectomy. They're so involved and intense, and with post-operative complications and issues, one would not do an esophagectomy knowing that there's advanced cancer spread to other places because of the reasons I mentioned to you. And similarly, we need to treat those places that it's spread to. And if you're trying to recover from an esophagectomy, that's just not possible. So that said, there will be instances where the primary tumor in the esophagus and or GE junction are blocking your ability to eat. And so the invasive procedure that we would consider here would be to place, again, a stent across this narrowing to help open things up and allow you to eat. Now, I will tell you that that would not be done in my practice as the first solution. The first solution in any situation, whether it's stage 4 or an early stage, like a stage 2 or 3 cancer, before getting surgery, is to get systemic therapy first and at any stage. And that's because by starting therapy, in an untreated setting is a high chance that this will shrink down and your swallowing will improve. With our therapies that we have available today, with chemotherapy with, say, FLOT in the early stage setting, or chemoradiation with carbotaxol, or in the metastatic setting with FOLFOX with targeted therapies if appropriate, it is a high likelihood that your dysphagia, your swallowing issues, will improve, if not resolve completely. And so we would avoid putting a stent in those settings, because in fact, in some cases where we see that done, then you start the therapy, the cancer shrinks down and the stent slips out because it's not being held there in place anymore. And then an endoscopist has to go back in and retrieve it. And so a stent is reserved for if and when systemic therapy is not working to control the primary tumor. And if and when that occurs, which is not uncommon in the metastatic setting, a primary tumor initially may respond well, but then over the months and years, it often is the problem where the metastatic sites are being well controlled, but the primary tumor is not. In that setting, I might consider doing radiation therapy. You can go to the video we did on the principles of radiation and learn about that. And in that setting, I might consider doing radiation alone or with chemotherapy if I want to be a little bit more aggressive, because the chemotherapy accentuates the effect of the radiation. And only if and when systemic therapy is not helping to control it, and we've already done radiation and it's problematic still, or it got better, but then it came back later, that's when I would consider doing a stent in the esophagus. And so an esophageal stent can be very alleviating of this obstruction, but stents come with complications, just like in the stomach one I was mentioning. They can get clogged, there can be tumor ingrowth, and so an endoscopist has to go in and unclog it, or put another stent inside the stent if there's ingrowth. And so again, we don't want to do that unless we've exhausted other less invasive approaches. In addition, stents, especially in the esophagus, more so than say in the stomach, can be painful. They can cause stretching there that patients can describe as being just uncomfortable. And also, they're not perfect. This is sort of a stiff stent. And so when you eat, normally in a normal esophagus, the esophagus stretches and it can accommodate the food coming through, as opposed to a stent like this is sort of fixed and stiff. And so I liken it to tipping over a 2-liter Pepsi or Coke bottle and expecting all the liquid to just come out very quickly. But as you know, it sort of has to bubble through. And so that's how this would work here. And you would have to learn that your eating is slow and steady, and drinking liquids in between after chewing very well, so that this food can get through. And so lastly, similar to after an esophagectomy where you've lost the GE junction to be able to prevent reflux, here, now this is propped open. And so lying back, a lot of the contents can just come straight back up. And so sleeping upright and things like this, especially if that stent is getting down to the GE junction and your cancer primary tumors at the far end of the esophagus and in the GE junction, you'd be at a higher risk of reflux when you lie backwards. So not eating right before bed, sleeping a little bit upright, etc. So again, palliation of these strictures, there are strategies, probably never surgery, stent after failure of other measures. Finally, I'm going to introduce the concept of oligometastatic disease, which is defined as a few sites of cancer spread, low cancer burden, but it is still stage 4 disease classically. And so there is actually debate as to what is considered oligometastatic disease, because it's sort of a subjective measure. How many sites is low and versus not? What's the threshold? And so an example of that is a recent paper where they tried to come up with criteria of what is and isn't oligometastatic disease. In general, just suffice it to say that it is low burden of disease, one organ that it's spread to, only one or a few sites. And also has to be controlled on therapy for some time. In other words, at the initial diagnosis, it may look like oligometastatic disease, but at the next scan, it could be that there are 10 more sites that became more apparent. And so being on therapy for a period of time and still having oligometastatic disease is a criteria. And so if one fits into this category, then one may consider more aggressive treatments with radiation or chemoradiation to the primary tumor, whether it's in the esophagus or stomach, and to wherever those metastatic sites may have been, with or without consideration of surgery of the primary site and or the metastatic sites. And so I'm going to talk about a dedicated video on this because it is such a common question. And so I will show some of the data that we do have to support this or not, and also some trials that have been designed to assess whether or not this could be helpful. There's also a special oligometastatic site that we've been noting along the way of the various videos, and that is peritoneal-only disease, like a diffuse type gastric cancer. And in those settings, there is the concept, as opposed to the Regatta study, which I showed you in a few slides ago, that was removing the primary tumor but leaving the peritoneal disease in the peritoneal cavity. So a lot of critics were like, well, what's that going to achieve? If you're going to do it, you need to take everything you can find out. And so doing the primary tumor resection and then something called cytoreductive surgery, or CRS, removing all of the known disease in the peritoneal cavity, and then putting chemotherapy inside, whether it's HIPEC or PIPEC, and we'll talk about that. And so I'll have a dedicated video on just this because it's such a common question, and we'll go into that in more detail then. But suffice it to say that your treatment team will be considering these, and if appropriate, may consider to proceed with one or both of these strategies. So in this video, I took you through the principles of surgery as it pertains to gastric and esophageal cancer. We talked also about local setting stage 1 disease and really localized cancers that can be amenable to endoscopic approaches from an interventional gastroenterologist, an EMR or an ESD. However, if it's more advanced, a stage 1B up to stage 3, then surgery is involved. And we talked about surgeries in the stomach, and that it really depends on the location in the stomach, also the extent, and also the histology in terms of what the surgeon will decide to do, as well as their expertise in terms of their comfort level of doing, say, open versus laparoscopic versus robotic. And similarly, we talked about different approaches in the esophagus for esophageal gastrectomies and esophagectomies. And so after numerous trials have assessed the various surgical approaches, none has consistently proven to be superior to others, and each provide excellent short and long-term results in the hands of experienced surgeons. And in fact, as I showed you, the available literature really suggests that the experience of the surgeon and their team and the hospital in the management post-operatively of both gastric and esophageal cancer patients are really what's paramount for operative morbidity and mortality rates. And ultimately, this all really supersedes the type of surgical approach selected. And then we talked about post-operative complications, and then we talked about some of the scenarios in the palliative setting of what procedures could be considered, but also avoided if at all possible. Thank you.